my assignment 1, my domain modelling, I've picked safe staffing. The acuity of patients' variance and nurses' hours is my clinical topic for this assignment, ensuring the right person is in the right place at the right time. So what is safe staffing? Safe staffing is when the acuity of care required by a patient matches that of care and skill mix required. Each ward has a minimum safe staffing level, so no matter if they have patients or not, they have to have a minimum number of nurses to open that area. The CCDM Care Capacity Demand Management Programme was developed from Safe Staffing Healthy Workplace Unit in partnership with the DHBs, NZNO and PSA. They developed this programme to implement the recommendations of the Safe Staffing Healthy Workplaces Committee of Inquiry in 2006. Safe staffing is now part of the MECA agreement. As part of the agreed MECA, it has to be fully operational and completely implemented in all DHBs by 2021. The Safe Staffing and Healthy Workplaces Unit is part of a collaborative agreement between the New Zealand Nurses Organisation and the District Health Boards. The unit's goal is to have staffing at workplace that assure patient safety and satisfaction, support staff health and well-being and support organisational efficiency. The Safe Staffing Healthy Workplace Unit sits within District Health Boards New Zealand and responds to the issues identified by the Safe Staffing Healthy Workplaces Committee of Inquiry through their report published in 2006. The Ministry of Health specifically funded the unit in recognition of the government's committee to advancing patient-centred improvements in service quality, and these are expected to flow from the work of the Safe Staffing Healthy Workplace Unit. Safe Staffing Guidelines. Appropriate staffing plays an important part in the delivery of safe and effective health and care. Safe staffing must be matched to patients' needs and is about skill mix as well as numbers, about other staff as well as nurses, and other settings as well as hospital. It is the responsibility of all health and care providers to ensure that safe staffing guidelines are followed, and if not, appropriate escalation pathways are delivered to managers if this isn't safe staffing in all areas. The rationale re me picking this topic is that safe staffing has a huge impact on patients' care, on patient outcomes and safety, including falls and incidents of pressure sores. It also impacts hugely on nurses' well-being and retention of nurses. It impacts on medication errors made by nurses, and it's something I'm involved in as part of my job on a daily basis. It is imperative that safe staffing occurs in all areas. My domain model is acuity of patients' variance and nursing hours. I've used a mind map to represent my decision support system, as this is a visual and easy flow to follow. The biomedical ontologies integrate the information from different databases and are organised and integrated from existing clinical databases. All the information is gathered and facilitates decision making. The semantic representation supports the DSS in the whole decision making process, and it is capable of encoding the request. The data relevant for and conclusions and suggestions produced by the DSS. Advantages of using an ontology-based representation of the main data structure are it allows to track and expose in a structured form that can be used in other services. It enables logic reasoning for some of the inference steps of the DSS decision-making process. The relationship between domains: promoting safe and effective nursing care, less harm to patients, improved job satisfaction, less medication errors, and improved patient satisfaction. The concepts for my DSS are unsafe nursing, medication errors, poor job satisfaction, higher fall rates, pressure areas increasing, and poor patient outcomes. Here we look at a mind map of the acuity variance for safe staffing. As you see, we've got two choices whether the acuity variance nursing hours, if they're in positive variance or if negative variance of nursing hours. So this is looking at the patient's acuity of what care that is required and what staffing we have got available. Depending on what the variance is like, then that would bring up maybe the variance response plan being activated. All areas would have a variance response plan, and in conjunction with the duty manager would look at putting different things in place. Nurses may be relocated to different areas, bureau staff to located as required, patients to be discharged as able, and some patients to be transferred to hospitals closer to home. Information systems are also developed for communication between professionals in the hospital. At our hospital we have what we call the HAG screen, which is Hospital at a Glance. This shows different areas and their variants and what type of patients they have in each ward. Often spaces in hospital are developed to support daily care coordination, but also these can still have physical barriers in supporting care coordination and negative variance for patient care if there are not sufficient nurses to reach the demand of patient care in particular. This is the HAG screen that's used at our District Health Board, which gives people a quick glance at what's actually happening with the hospital status. This is also an area that I feel my DSS could feed into, and it would also give a lot more clarity around what should happen and what potentially could happen with an acuity of when the acuity variance is showing negative. The HAG screens have been developed to support decision making on several levels, and it's somewhere my chosen DSS could actually feed into. My DSS is a system that can be used in tactful decision making when planning the use of the nursing resources in the near future, as well as in strategic decision making when analysing cost and planning budgets. A large number of the information systems were developed to support strategic and tactical decision making based on information concerning nurses and patients, in particular for planning and performance evaluation. There have been attempts to connect organisational design with outcomes, effectiveness and efficiency, and process-based organisations have been shown to improve hospital efficiency. Nurse managers' decision-making occurs often in situations where decisions must be made without delay, and based on the findings in the literature, it seems that operational decision-making is weakly supported by information systems and real-time information. Some of the limitations found in my decision support system is the accuracy, reliability and validity of the data being entered, staff who are unable to be moved due to skill mix, lack of bureau staff vacancies unable to be fulfilled, and interoperability limitations.